Respected Chairperson, moderator of the session, learned audience from home and abroad, good morning and Assalamu alaikum. I, Dr. Tasneem Hossain from National Institute of Cancer Research and Hospital, am going to present my paper on assessment of waiting period for diagnosis and treatment of patients with cervical carcinoma and factors responsible for delay, a retrospective analysis. According to the reports of Globocan 2022, cervical cancer is the 8th most commonly diagnosed cancer and 9th most common cause of cancer mortality worldwide. However, if you look at Bangladesh data, it is the 2nd most common cancer in women and 4th most common cause of cancer mortality. According to the hospital-based cancer registry of National Institute of Cancer Research and Hospital, Dhaka, cervical cancer is the 3rd most common cancer, accounting for 10.9% of all cases, and majority of the cases are diagnosed at an advanced stage. The principal aim of the study was to assess the delay in diagnosis and treatment of cervical cancer patients and factors underlying which were responsible who attended NICRH, the single government comprehensive cancer hospital of the country. With this view, we aim to assess the duration of delay in every step from appearance of disease to receiving treatment, to evaluate factors responsible for delay to diagnose and treat the disease, to find out demographic characteristics of patients, to dictate future measures to overcome the challenges. This was a retrospective observational analytical study carried out at Department of Radiation Oncology, National Institute of Cancer Research and Hospital, Dhaka. It was carried out from 1st January 2024 up to 30th October of 2024. 200 randomly selected cervical cancer patients who attended follow-up at NICRH, who were treated between January 2021 to September 2024 were included in the study. A pre-tested semi-structured questionnaire was used as data collection sheet, which was used for face-to-face interview and collection of record from patients' treatment record file. Data was analyzed with MS Excel and SPSS software. When we look at the results, most of the patients belong to 45 to 54 years of age group, which corresponded to the results of NICRH data. Most of the patients were multiparous and were married. When we look at the socioeconomic status of the patients, most of the patients were housewives, and most of the patients' husbands were had farming occupation. Most of the patients had monthly family income of less than 25,000, which is about less than $200 per month. Educational status of the respondents showed most of the patients were illiterate, but their husbands crossed the primary education bar. Most of the patients came from Dhaka division, followed by Chattogram division. And when we assessed the awareness about the screening program, only a few number of patients, that is about 8% of the patients were aware about screening program, that is VIA. Mostly first appeared symptom was parvaginal foul-smelling discharge, and most of the patients attended gynecologist as for first medical attention. But a good number of patients went to MBBS doctors and also village healthcare providers. First confirmation of diagnosis of most patients were by histopathology at NICRH, as well as the first clinical staging was also done at NICRH. The highest technique used for imaging for most of the patients were ultrasonography. MRI and CT scan was used for very less amount of patients. When we analyzed interest in doing investigation at private centers, most of the patients were interested to do investigation at private centers, but they were not interested to do treatment at private centers because the cost of treatment at private centers were 2 to 3-fold. First oncological advice from multidisciplinary tumor board was from NICRH in most of the patients. We also assess the discrepancies in clinical and radiological staging. There was a significant discrepancy found, statistically significant discrepancy found in clinical and radiological staging. If we when we assess the delay in appearance of first symptom to first medical attention, it was median time was 240 days, and the significantly affected factors were feeling of embarrassment, lack of awareness and education, lack of family support, and social stigma. Delay from first medical attention to histopathological confirmation was median time was 210 days. And the significantly affected factors were distance of referral center, lack of timely referral, lack of proper gynecological evaluation, and unavailability of lab facilities. Delay from histopathological confirmation of diagnosis to getting oncological advice or attending an MDT was median time 45 days, and the factors responsible were lack of family support and distance of referral center. The median time of delay from MDT decision to undergoing surgery was 70 days, and the significantly affected factors were economic insolvency, distance from referral center, and queue in surgery. The median time in delay from MDT decision to receiving radiotherapy was 210 days, and the significantly affected factors were economic insolvency, distance, lack of proper counseling, and queue in radiotherapy. The median time in delay from receiving ICRT from EBRT was 14 days, and the significantly affected factors were appearance of toxicities and fear of ICRT. So if we assess the delay, the mainly delay occurred from primary symptom to first medical attention, and also there was delay from MDT decision to receiving RT, which was also significant. So if we analyze the factors responsible, mostly social factors were responsible for delay in first medical attention. Economic, infrastructure related, and lack of trained personnel and facility related factors were responsible for delay in histopathological diagnosis, and similar factors were responsible for delay in treatment along with queue in surgery and radiotherapy and treatment related toxicities. So dealing one of the most common cancers of women in Bangladesh at government hospital poses great challenges. Dealing with the issue in future requires raising awareness about a screening program, dedicated national projects, availability of trained specialists and infrastructure at periphery, dedicated radiotherapy suite setup for such cases, and finding out hyperfractionated options. These are essential to deal the undue delay to improve treatment outcome. These are some of the references I used for my study. I acknowledge all who were involved in the study. Thank you all for your patient hearing.